Hi everyone, my name's Ramsey and I'm a research fellow working at the Yorkshire and Humber Patient Safety Translational Research Centre, and I'm working in the patient involvement in patient safety theme of work. But today I'm going to present to you some of the findings from my PhD, which is focused on how healthcare staff respond to and use online patient feedback to inform improvements in practice. So to start with, a little bit of background about patient feedback. So recent NHS guidance and policy provides us with a promising rhetoric, suggesting that a more patient-centred approach to care is being adopted, and that patients are being increasingly recognised as a valuable resource to inform improvement. They often give us those unique and insightful perspectives into their healthcare experiences. And in line with this, over the past decade, the NHS has been increasingly collecting feedback from patients, so via mandated tools such as the Friends and Family Test and the National Inpatient Survey. But alongside that, patients are also increasingly reporting about their healthcare experiences online, so on social media and on platforms such as NHS.uk and Care Opinion. So despite this increasing uptake from the patient perspective, with benefits including anonymity, feedback being real time and the breaking of geographical barriers, few healthcare professionals are asking for patients to provide their feedback in this way, so concerns from their perspective include deliberate gaming, and the feedback being made available to a wider and unknown audience in the absence of contextual cues. Additionally, research suggests that focus has largely been on feedback collection and meeting response rates targets rather than meaningfully using that information that's being collected. There's some suggestions that while we may be hitting those targets, are we missing the point with feedback? Additionally, challenges for staff looking to use feedback for improvement purposes include staff being defensive in their response to negative feedback, misconceptions that feedback is purely complaint, so a lot of the feedback is often either praise or constructive criticism to avoid negative experiences for themselves or others in the future, and staff feeling overwhelmed by large volumes of unfiltered and untimely data arriving via different sources. Then also having the sense of insufficient authority and autonomy to deliver change based on what they're hearing. So based on those issues that have been identified in the literature, this is the first phase of my project. So phase 1 was a qualitative study which explored the different response types that staff give to patients online via Care Opinion. So for those of you who are not familiar with Care Opinion, it's a national not-for-profit platform where patients can go online and provide free text narratives regarding their health and social care experiences in the UK. And that site also interoperates with what was previously known as NHS Choices. And this study is published in the Patient Experience Journal if you want to go and have a look at that study. That I use framework analysis to qualitatively analyse a purposive sample of just under 500 patient stories and their responses to online feedback on Care Opinion. And here you can see some of the key characteristics of that data. So as you can see, the majority of the stories reported positively about their healthcare experience. The majority of those patient stories did receive a response from a healthcare member of staff, and the majority of those responders specified their full name and their role. So using the qualitative analysis, I identified 5 key types of responses that staff provide online, and in the next few slides I'm going to give you an example. To start with, we've got non-responses, so 11.7% of the stories that I looked at didn't receive a response from a healthcare professional, and this data was extracted 3 months after the stories had been published. So research suggests the majority of stories that will get a response do so within that 3 months. However, there are some examples where stories are receiving responses much later. And next to the title, to the response type, you can see the smiley faces, and this is representative of the sentiment of those stories which prompted the response type. So as you can see, there was quite similar amounts of positive and negative stories that were prompting this non-response. And then we've got generic responses. So these don't always appear tokenistic instantly from that instant read. So for instance, some organisations will craft a response to centre all positive stories and all negative stories, so there's no kind of personal element in there. It's just simply a copy and pasted response from the organisation's behalf, and as you can see, the majority of those were prompted by a positive story. And then we've got appreciative responses, so these were the most common response type, which were bespoke to the patient's story and tended to pick up on some of the details what the patient was communicating. So giving thanks and apologies where appropriate, and often thanks were given for patients spending the time to articulate their healthcare experience, not necessarily thank you for the feedback that they were communicating. And they might highlight specific staff members or teams that their feedback will be being passed on to, so the patient knows that somebody has read their story and has crafted a response. And then I've got offline responses. So this is where staff want to continue the conversation around the feedback, but they want to move that conversation offline. So you might get a staff member giving their personal telephone number, their email address, or quite often staff will ask patients to contact PALs or complaints to repeat their story by the mechanisms that they're more embraced within the organisation. And that can be for a variety of purposes, so to streamline, for capacity, but also where organisations don't engage with online feedback and are kind of redirecting them via the more traditional form. And finally, we've got transparent and conversational response types. Now, interestingly, these are the response types that are least often given by staff. So as you can see, 6.5% of the responses that I looked at were transparent and conversational in style. However, there has been some research done from the patient perspective, and these are the response types that patients would most like to see. So these are examples of staff engaging with the online communication method and being transparent and open in that conversation with the patient, engaging with what the patient is communicating, and highlighting where interventions are either planned or have been implemented based on what the patient is saying, or maybe interventions can't be implemented based on what the patient is saying, but being transparent about that, talking about the barriers and facilitators around engaging with that patient feedback and making change based upon it. And we found that the way in which organisations tend to respond to feedback on care opinion was influenced at an organisational level, and by that I mean that organisations most often adopted a single or multiple response types and stuck to that way of responding to all stories regarding their organisation. So phase 2 of my project used ethnographic methods to explore how feedback was used in 3 different NHS trusts, looking at those cultural contexts in which those responses were given. So we have Site A, which was an organisation that didn't engage with those patient stories on care opinion. Site B, who sent those generic responses, so a copied and pasted response to all stories regarding their services. And then Site C, which gave high levels of those more transparent and conversational responses to patients. And the ethnographic methods included observations of practice and ad hoc conversations with staff, and using the detailed field notes from those observations, some documentary analysis of relevant data, so protocols, reports, Twitter activity, website content, and then some one-to-one detailed semi-structured interviews with staff who have an interest in patient experience at those organisations, and that was used to produce 3 in-depth site case studies and then a multi-case analysis. So here we've got Site A, who was a non-responding organisation, so didn't publicly engage with the care opinion or send any responses to the stories that we received about their services. And some of the key features of this case study was the sense of organisational firefighting. So there's a relatively small centralised team of staff working with an overwhelming amount of feedback arriving, often via PAL, so via email, telephone and face-to-face, dealing with patients often in states of distress, raising complaints and negative feedback, and that led to a hierarchy of feedback mechanisms, so specific feedback mechanisms were prioritised, which led to online feedback largely being ignored. There was also this sense of a roadblock of anonymity. So at Site A, where patients were anonymous, which they were online, but also some patients wanted to remain anonymous via the more traditional mechanisms such as telephone, the journey of the patient feedback stopped once patients wanted to remain anonymous, and staff had a sense that they couldn't do anything with that data because patients were anonymous. They didn't know who to go to get answers for the patient or how to make any changes based upon it. And then we've got Site B, who sent out those generic responses, and this function was held, interestingly, in the communications team. So the patient experience team or frontline staff didn't tend to get involved in those online responses or processes around that. So there was a sense of siloed working, that teams across the organisation didn't really communicate what each other wanted and their preferences around working in online feedback. It was just sent in a series of processes to the different teams, and those responses were used to channel shift. So the communications team would send on those generic responses that would invite patients to contact PALs. And largely staff felt disenfranchised with online feedback. They didn't feel that it really influenced the work that they did. They didn't engage with it in their daily work, and they felt that time would be better spent investing in learning from their known themes and trends within the feedback rather than additional mechanisms such as online. And then finally, Site C, who use more of those transparent conversational responses. So online feedback became kind of embedded in their culture, where story-based patient narratives were part of everyday practice in the organisation and seen in all different kind of routine processes, from trust induction to board meetings. And it was originally prompted by wanting to shift the culture, so followed by the Francis report from mid-staff. They thought that being transparent and placing their feedback online would help them to shift the culture, but it's also helped to embed and perpetuate that culture over time with their journey with care opinion. So we've got a staff member here saying we expect and we encourage feedback, and so the example is set in terms of wanting to respond to it. It's that whole kind of circle and the culture we encourage. I then conducted a multi-case analysis to make comparisons across those 3 case studies and draw higher level conclusions. And some of the key themes across that large data set included that, firstly, the meaning of feedback was a largely determining factor, so how the organisation understood patient feedback and the rationale for collecting that information helped to inform a lot of subsequent activities. So for instance, how that information was collected and processed, who became involved or excluded from those processes, to what extent those processes were resourced and supported by organisational infrastructure, to what extent patient experience information was humanised. And by that I mean whether the complexity of patient stories were maintained or whether that information was turned into numbers and statistics, and how that feedback was then used in practice or not, and for what purpose. And 3 distinct approaches in the 3 case studies were evident, deriving from different understandings of patient feedback. So at Site A, feedback was recognised as a case, and the focus was on listening, resolving and closing those feedback cases as quickly as possible, and there was little time for learning from what patients were communicating to them. At Site B, feedback was recognised as data, and the focus was on logging, counting and reporting information routinely, with some pockets of innovation where data was being used purposefully for improvement. And finally, at Site C, narrative feedback was embedded in the culture, and the focus was on responding openly, learning from service users and driving meaningful improvement. There were also different approaches to managing online feedback more generally, which was either in isolation or in different variations of collaboration. So at Site B, online feedback was kept almost exclusively within the communications team, and they were often distanced from frontline staff who those stories concerned. However, at Site C, the responsibility of feedback was devolved at all levels of the organisation, which helped to reduce contextual blindness, which was seen at Sites A and B, and helped staff within the core team to build partnerships with similar centralised teams, which other sites struggled to build those relationships. And at all sites there was a reporting versus action dilemma. So there was different percentages of their time and resources allocated to collecting patient information, reporting on that information, and then the action derived from what they were hearing. So at Site A, almost all of their time was spent on collecting feedback, so they were often overwhelmed with patients calling, writing letters, writing emails, so a lot of their time was spent on dealing with the information that was incoming. Whereas at Site B, reporting was heavily invested in, and staff spent a lot of time and effort to produce quite sophisticated and detailed reports, which were often the focus of team meetings. However, it was apparent that sometimes the reporting of this was confused for the doing, so there was little focus on how they were going to use that information that they were hearing, and a lot of the discussion was around, we've had so many complaints, we've had so many care opinion stories,
And then at typology, there was a large team that spent a lot of time and effort to not only collect patient feedback and report on that to the wider organisation, but encouraging staff to take the time and space to consider how they might learn from what they're hearing and what might change subsequently. And there were also key catalysts for progression, stagnation and regression within the organisation. So at all sites, online feedback was seen as a relatively novel means of collecting patient experience information, even at typology where it had been culturally embedded over a number of years. And there were also varying levels of frontline staff having a sense of permission to innovate, which came from our overall organisational culture, which was influenced by teams, but also by key individuals, so such as head of patient experience and chief nurses. And changes in staff in these kind of roles ultimately had a large effect on the culture of the overall teams in the trust and how patient experience information was used.
Thank you very much for listening. I realise that is a really kind of speedy tour through a big data set and lots of analysis, so if you have any questions or comments, please add them as a comment below the video and I will read through those and respond to any comments that are posted. Thank you very much.